In this video, we're going to take a quick look at the respiratory tract. Now, in previous videos, we've spoken about the mechanics of respiration, being how do we get that air into our lungs from outside the atmosphere, and how do we bring some of that air back out? And we spoke about some of the important muscles that are used in this process, inspiratory muscles and expiratory muscles. And we spoke about Boyle's law, the fact that when you take that thorax, which you could think of as being a box with the lungs inside, that when you change the volume of that box, you are changing the pressure inside. So for example, when you go to inspire air, you need to contract certain muscles such as the diaphragm, which pulls down, and the external intercostals that pull the ribcage up and out to increase that thoracic volume. As you do this, increasing that thoracic volume decreases the pressure inside of your lungs. And we know that gases love to travel from an area of high pressure to an area of low pressure. So if the pressure inside of your lungs is lower or reduced, air is going to rush in towards it. Now the opposite happens when you want to expire or bring that air back out. Certain muscles will contract to reduce the volume of the thoracic cavity and therefore reduce the volume of the lungs, increasing the pressure in the lungs, and air is going to rush out, going again down that pressure gradient. Now what we need to talk about is what happens once we bring that air in, what happens once it gets inside of our nasal cavity and then goes to our oral cavity and our pharynx, which is basically the back of our throat, our larynx, which comprises of the voice box, down through our trachea, bifurcates to our bronchi, continues to split off into further smaller bronchi and then bronchioles, and then ultimately to our alveoli for gas exchange. So we're going to take a quick look in this video at the process starting at the nose or nares and moving down to the alveoli. So we've taken that first breath in, we've inspired that first bit of air. What do we have? Well, we take that air into our nares, which is our nostrils or our nose, and we inspire that air. Now, we know that we have what's called vibrissae, which are basically nose hairs. And this vibrissae is that first line of defense to protect the inside of our respiratory cavities from the external atmosphere. So vibrissae are those nose hairs. Now, as we get in, we end up hitting the nasal cavity. Now, the nasal cavity has some very important anatomical structures or features associated with it, which impart very important physiological properties. So, first thing is that if you to have a look and feel that nasal cavity, this is further than bringing your finger inside your nose. This is still in your nostrils as you do this. You need to go back inside your nasal cavity. You'll find a couple of things. One, it's quite moist. That's the first thing. And two, there are these very fine hairs called cilia that line your nasal cavity. Now, the tissue, which is going to be epithelial tissue, because we know epithelial tissue lines cavities, okay? The epithelia that lines our nasal cavity is what's called pseudostratified ciliated epithelium. So pseudostratified. When we look at epithelium, we break it down according to its structure, and that structure tells you something about its function. So for example, if you have one layer of epithelial cells, okay, that's a simple layer, that's what we call it. If you have many layers of epithelial cells packed on top of each other, it's called stratified. If you have a single layer of epithelial cells but actually looks like many layers, that's called pseudostratified. So we have pseudostratified epithelia inside our nasal cavity. I also said that it was ciliated. Now these are even finer hairs than that vibrissae within our nose. And this cilia again captures particles. The other important point about this olfactory epithelia, or the nasal cavity epithelia I should say, olfactory epithelia is a bit further up. This nasal cavity epithelia is that it is highly vascularized. So there's a lot of blood vessels, and just underneath this epithelia, we have what's called goblet cells. Now these are cells that secrete mucus. So we've got ciliated mucosa that's releasing all this mucus, and it's highly vascularized. So you need to remember that, because as you bring that air in, the cilia and the mucus capture any particulates or particles or pollutants that should not be in the nasal cavity, okay? Furthermore, should not get all the way down into the alveoli, because that is quite dangerous. That's the first thing. Second thing is, you can see I've drawn these weird structures here in the nasal cavity. These structures are important. They're the conchae and meatuses, very strange names. Conchae is the bump out that you'll see, and then meatuses are the groove in. So they actually look bump out, groove in, bump out, groove in, bump out, groove in. Like I said, bump out are the conchae and the meatuses are the groove in. And what this creates is something called turbinates. So they're also known as the turbinates of the nasal cavity. And when you inspire air, as the air comes in through your nostrils, it will hit these scroll-like structures and the air will start to spin, hence the turbination. So the air starts to spin around and becomes turbulent within the nasal cavity. Why do we want this to happen? Well, as that air comes in, the more air that spins around, the increased likelihood that that air will touch that olfactory mucosa. That means the more likely filtration will occur. So particles or particulates are going to stick to that mucosa and the cilia are able to grab it and throw it. Now, where do the cilia throw these particles? Well, it can throw it out through the nostril or it can throw it to the back of the throat for us to swallow. And we actually swallow quite a fair bit of this particulate-laden mucus every single day, okay? So that's one thing, is that these turbinates increase filtration. What else? Well, I told you that our nasal cavity is highly vascularized, so there's a lot of blood vessels there, and this is important because it warms up all that air that's coming in, which means it doesn't matter if it's -2 degrees outside, as you bring that cold air in, it touching all this vascularized tissue will heat it up. Because as that air gets down to the lungs, ultimately, we want it to be 37 degrees. So it filters the air. This is what this mucosa does. Filters the air, heats up the air, and it does one more thing. It humidifies the air. So that means it starts to attach all these water molecules, starts to make that air quite moist. And again, that's important for when that air makes it down to the lungs for appropriate gas exchange to occur. So these are some important properties of the nasal cavity. Now, there's some other things that you can see associated with the nasal cavity, such as these little holes here. Now, these are called sinuses. Now, what we have up here is actually the cranial cavity. That's where the brain sits. And you can see the spinal cord would sit within here, and you've got the vertebrae either side. So you've got the bodies of the vertebrae, and you've got the spinous processes of the vertebrae here. So this isn't part of the respiratory system, obviously. It's just for perspective. So these two areas here are called sinuses, and they're hollowed out areas of bone within our skull. Now, these sinuses are also covered with this epithelium, okay, with this mucosa. So it's vascularized, but not as vascularized as the nasal cavity. But again, it has mucus cells and cilia and so forth. There's little areas of conduction so that the air can get in and that air can get out. Now, why do we have these sinuses? Well, it's a contentious point. We don't necessarily know exactly why, but we do know that these sinuses help for resonation. Okay, so when it comes to vocalizing or vocalization, they help for resonating sound. That's one point. The second point is that if you've got numerous holes in this very thick skull, it will lighten the skull. So it makes our head a lot lighter for us. But obviously problems arise because this tissue, similar to the epithelium within the nasal cavity, is prone to infection. And when something's prone to infection, inflammation occurs, and inflammation always leads to excess secretion. In this case, it'll be mucus secretion, and it blocks up and it forms air pockets like vacuums. And this is what leads to those headaches, those sinus headaches that you get. Okay, so this air's come in. It's been terminated by these conchae meatuses. It's touched the nasal mucosa, and it's filtered, it's warmed up, and it's humidified. A couple of other things is that what you'll find at the very top here of the nasal cavity are some holes through this bone. Okay? Now, this is called the cribriform plate, part of the ethmoid bone, and neurons project through, called olfactory neurons. Now, these olfactory neurons that project through give us that sense of smell, so that when all these particles come through, the more air that turbinates, the more likely some of those particles or chemicals that we've inhaled touch these olfactory neurons. This chemical signal gets transduced into an electrical signal, goes up to the olfactory bulb in the brain, and we make sense of some smell that has come in. This is important clinically because some people may come in and they've lost their sense of smell, and this may be because they've had some sort of knock to the head. Now, the first question wouldn't be, have you had a knock to the head? It may be, do you have some sort of nasal infection or a cold? Because we know when this happens, it reduces, or we even can sometimes lose for a short period of time, our sense of smell. A knock to the head can actually shift this cribriform plate and this ethmoid bone, and it can actually shear off those neurons that are projecting through, and hence losing that sense of smell. Okay, the air that's come in that we've just inspired is warmed up, filtered, humidified, so forth. It's going to come back through to the pharynx. Okay, now the pharynx is basically the back of the throat, and there's three parts of the pharynx. You've got the nasopharynx, you've got the oropharynx, and you've got the laryngopharynx. So nasopharynx, oropharynx, and laryngopharynx. So nasopharynx is basically the back of the throat at the nose, oropharynx is the back of the throat at the mouth, and laryngopharynx at the back of where the larynx is, basically our voice box. And we'll do a whole lecture talking about the voice box and creating sound and phonation and so forth. So these are all different parts of the pharynx, which is just basically this muscular conduction system moving all the way down. Now, as we get to the back, let's just say we've gone past the nasopharynx, we're going down to the oropharynx, and we know we can inspire air through the mouth. That's just the tongue there. We can inspire air through the back of the mouth, go into the oropharynx, and we start to move our way down. Now, we've got this important structure here called the epiglottis. Now, the epiglottis is this cartilaginous structure, which when we go to swallow food, the tongue moves up and back. That's part of the swallowing process called the buccal phase of swallowing. The tongue moves up and back, pushes on the uvula, which is the punching bag at the back of the throat, which blocks the nasopharynx aspect. The tongue moves back, pushes down in the epiglottis and blocks the laryngopharynx aspect and blocks the trachea, so that when we swallow food, there's only one place for it to go, and that's right to the back of the throat, down this tube here called the esophagus. And we know the esophagus leads to the stomach. But we're talking about inhaling air, and we don't necessarily want much air inhaled into our esophagus, even though inevitably that happens. The majority of our burps are actually just inspired air coming back out. So we've inspired this air, it's coming in, and we want it not to go down the esophagus, because the esophagus is predominantly closed due to these esophageal sphincters. It's smooth muscle, and it's predominantly closed, and sometimes it will open. But we want this air to go down this tube that sits anterior or in front of the esophagus, called the trachea. Okay, so here we're at the start of the trachea. Well, let's just say most superficial, or not superficial, most superior, I should say, to the trachea is the larynx. Now, the larynx is where our voice box sits, and there's numerous cartilage, tendons, and so forth associated with the larynx, and also vocal cords as well, which have sort of drawn up the opening here, which are associated with creating sound. Now, again, this is going to be the focus of another lecture, so we're just going to pass the larynx now. As we hit the larynx, we're going to start to move down into our trachea. So what I've drawn up is the larynx here with the laryngeal prominence. Now, this is also known as our Adam's apple. Sorry, up here, the laryngeal prominence. That's the Adam's apple, which both male and females do have. It's just more prominent in males because it's known as a secondary characteristics, and hormones can start to produce that prominence more so than others. Laryngeal prominence, Adam's apple, and we go down and you can see the bulk of the trachea. This is where the air starts to move down. Now, air can be inspired or expired through this tube. One important thing that you're going to find is that this tube is surrounded or has numerous C-shaped rings associated with it that are made of cartilage. So the cartilaginous C-shaped rings all the way down. How many of them are there? Of the trachea, around about 16 to 20 cartilaginous C-shaped rings. The opening of the C-shaped ring is at the back. What's at the back as well? The esophagus. So the opening of the C-shaped ring actually articulates with the esophagus, and this is important because as you swallow food, the esophagus begins to distend. Now, some of us don't chew as well as we should and swallow like ducks, big particles of food, bringing it down, and that distends the esophagus so much that it can potentially impinge on these C-shaped rings. Imagine if they were fully closed, the food will get caught and unfortunately wouldn't be able to propagate your genetic material to the next generation. So we've evolved to have these C-shaped rings so that they can distend with the esophagus if need be. 16 to about 20 of them as we move down. Now, that's the cartilage of the esophagus. If you look inside, we've still got that pseudostratified, starting to become more columnar, cuboidal epithelium, still has cilia associated with it, and still has goblet cells secreting mucus. Now this is important again because once we inspire more air, we will start to capture particles in this mucus, and the cilia, which has movement properties, start to push these particles captured in the mucus upwards. This is known as the mucociliary escalator. And it's important because as we inspire all this air, we start to inspire crappy material that we just don't want down in our lungs. Luckily, it's captured by the mucus and thrown up. What happens once it gets thrown up? It gets pushed right back to our esophagus and we swallow it. Why would we want to swallow it? Because in our stomach, we have very acidic chemicals. We've got hydrochloric acid there and other lysozymes and so forth, which can break all this stuff down, okay? So, we've got all this. Now, another important point clinically is that smokers, people who smoke cigarettes and so forth, inhale that smoke, it starts to destroy the cilia. So the cilia begin to die off. What does that mean? It means the particles get caught in the mucus and, because gravity sucks, pulls things downwards. Where does it go? Into the lungs. Hence the reason why smokers early in the morning tend to cough and cough and cough, trying to bring up all that crap that the cilia that they no longer have couldn't bring up. So it's down inside their lungs. Okay, as we go down the trachea, you'll see that the trachea bifurcates. This is also known as the carina, and it bifurcates at around about T4, T5. So thoracic vertebra 4, thoracic vertebra 5 is where it bifurcates or splits into two. This is now what we call the bronchi. So we've got the trachea here, and now it's split off into the right main stem bronchi, also known as the right primary bronchi, and the left main stem bronchi. Okay, so as it splits off, you can see it still has cartilage, but this cartilage isn't necessarily C-shaped anymore because there's no esophagus going behind it. So you can see it has this non-uniform pattern to it. So it splits off. Now, another clinically important point. The right main stem bronchi compared to the left main stem bronchi is a little bit different. One, it's wider in diameter, and two, it's more vertical. Why is this important? Well, it's important because sometimes children or even adults can inhale objects which they potentially shouldn't, maybe like a peanut, and it may get caught down in their respiratory system somewhere. Where do you think is the most likely place for this peanut to be lodged? It's going to be the right main stem bronchi because it's wider and more vertical. Now, splits off into two, and you can see that this splitting off into the left and right main stem bronchi, it will split off again. Now, this splitting off into secondary bronchi, okay, splits off on the right hand side 3 times. 1, 2, 3. And on the left hand side splits off 2 times. Okay, into the superior and inferior, and this is superior, middle, and inferior, and these will go to the various lobes of the lungs, which means that on the left hand side, the left lung has 2 lobes, and on the right hand side, the right lung has 3 lobes. Why is this the case? Is because you're going to find that the left lung actually has an area cut out of it. Okay, now this is called the cardiac notch. Cardiac notch tells you about the heart. This is to make room for the heart because we know the heart sits predominantly to the left hand side within our chest. Okay, so it's that left lung is a little bit smaller or reduced because of that cardiac notch. So there's only 2 lobes. The right lung has 3 lobes. Now, this branching continues, about 23 to 25 more times, like a tree branching. And as it branches, it gets smaller in diameter, these tubes. they go from bronchi, and once they hit about 1/2 mil, they turn into what's called bronchioles. So trachea, left and main stem bronchi, secondary bronchi, and then branch about 23 more times till they're about 1/2 millimeter in diameter, and now they're bronchioles. Now, what's the difference structurally or anatomically going from trachea to bronchi all the way down to bronchioles? A couple of things. One, the cartilage reduces. Once you hit bronchioles, there's no cartilage, okay? But what does increase as you move down is smooth muscle. So here in the trachea and bronchi, we have very little to no smooth muscle. As we start to go to the smaller bronchioles, we have huge amounts of smooth muscle. Now this is important because of asthmatics, okay? Smooth muscle, as muscle, can contract, relax, contract, relax. It actually can alter the diameter of those airways. When somebody has an asthma attack, it can lead to constriction or contraction of that muscle that ultimately leads to constriction of those airways, which means in an asthma attack, it doesn't happen at the trachea, doesn't happen at the bronchi, happens all the way down at the smaller bronchioles, and that's where the airways start to close up, okay? So a lot of smooth muscle at the bronchioles, not much cartilage. Up at the trachea and bronchi, not much smooth muscle, a lot of cartilage. Okay. As we continue through, we also get reduced amounts of goblet cells and reduced amounts of cilia. Once we hit the bronchioles, no goblet cells, no cilia. You may be thinking then, how do we capture all those particulates? Well, luckily, in our alveoli sacs, this is where gas exchange occurs, we actually have important cells called macrophages. These are cells that eat up, big eaters actually. Macro meaning big or large, phage or phage meaning to eat. So they're big eaters and they help pick up anything that's left over. Hopefully by then there's not much that's getting past all those systems. So as we move down, we're ultimately at the bronchioles, 1/2 millimeter in diameter, and it gets small, and there's two major types of bronchioles. There are, as we move down, let's just say, we'll draw up some branching here. Okay, so what we've got here is how the bronchi turn into bronchioles. And we're going to have, let's say these are bronchi. Now these bronchi, they may be secondary or tertiary, or maybe the 10th branching or 20th branching maybe. And then we get down to 1/2 millimeter in diameter. We're going to have terminal bronchioles. And then at the very end, we have respiratory bronchioles. Okay, what's the difference? Well, terminal bronchioles are the very end of what we call the conducting pathways, meaning basically the tubes. These are just tubes carrying air all the way to the terminal bronchioles. Okay? The respiratory bronchioles tells you something important because the term respiration clinically refers to gas exchange across a membrane. Okay? It's actually ventilation, which means bringing air in and out, not respiration. Respiration is gas exchange at a membrane. So here where we have the respiratory bronchioles, this is also where we have our various alveoli and alveolar sacs. Okay? Now these alveoli are like bunches of grapes, and they're bunches of grapes like this because they increase the surface area. Why do we want to increase the surface area? If you were to unfold all of these alveoli, it'd be the size of a tennis court, okay? All inside of these pleural cavities that encase our lungs. These alveoli are there for gas exchange, so that means oxygen will jump out into the bloodstream that surrounds, so the pulmonary arterioles, or the pulmonary circulation, and the carbon dioxide will jump back in for us to breathe out. So gas can jump across them very easily. These alveolar sacs are 15 times thinner than a piece of paper, okay? So that membrane is very, very thin. So I think that will do us for going through the respiratory tract, broken up into the nasal cavity, oral cavity, pharynx, which is oropharynx, nasopharynx, laryngopharynx, then the pharynx, which houses the voice box, and then we've got the trachea, we've got the left and right main stem bronchi, which branch 23 times, ultimately into these structures called terminal bronchioles, the respiratory bronchioles, and then we hit the alveoli, which is the site of gas exchange. That's a very quick run through of the respiratory tract.